rising star and coming in from Rome in the field of phlebology. Congratulations on your recent meeting and vein in Venice.
Thank you so much. Thank you for the kind invitation. I really appreciate and I love your job, your podcast. And thank you for the question. Yes, we are pretty happy and excited about Vein in Venice. And this year, we almost doubled the participant. We have a great discussion, great speech. So it's amazing how things are going in the symposium. And I hope we will be able to do even better next year.
I'm still hearing the buzz about the meeting, so congratulations. Dr. Palombi is a counselor of the Cura Bene Roma Association. He's the scientific director for Medicare Magazine and the co-chair of the meeting. So can you tell us a little bit about this new technology that you've been developing, Total EVLA?
Yeah, thank you so much for the question because it's a new topic and not really new for someone. It's not a technique that I have invented. It's been invented by other colleagues, Michael Prüfer, but others technique with similar basic procedure called Atta technique, porcupine. So I'm not the inventor, but I think it's a really new topic, a new technique to consider for a selected patient, and I think it's a really useful technique. So if you want, I can share with you some slides and a presentation.
Please do.
Okay, so thank you so much. My disclosure. Well, total EVLA means basically treat not just the truncal vein with the laser, but also use the thermoablative technique to treat side branches and perforator veins during the same procedure. Of course, this is the question that I often receive by other colleagues. It is really necessary to treat collaterals. Well, the answer, it's not mine, but it comes from some study and, of course, from the guidelines. Regarding the study, I really loved and to read this one. It's a review that basically show us comparing the two groups. One in which there was performed concomitant treatment of the collaterals during the main procedure of ablation of a truncal vein, GSV, SSV, or anterior accessory saphenous vein, and the other group in which there was a staged treatment. 15 studies have been included in this review with almost 7,000 limbs. And what was possible to observe was that the reintervention rate were significantly lower in the concomitant group, and no great difference in terms of complications. So no more complications in the concomitant group respect to the staged. So no more DVT or other major complication. And instead, it was possible to observe a lower venous clinical severity score in the concomitant group. So this review, it's really interesting and tell us that treating the collateral veins during the main procedure could give to our patient a better quality of life after the treatment with no adjunctive or more complication respect to the staged strategy. And if we take a look at the guidelines that we do now have, what they tell us basically is that if we have a patient with, for example, GSV trunk or SSV trunk insufficient with collateral veins in a symptomatic patient, we can decide to treat, of course, this patient with a concomitant procedure of phlebectomy or foam with class 2A level B of recommendation. So it's not really high, but if we take a look at the chart has the same recommendation that we can find, for example, in treating patients not with thermoablation. So if you decided to treat with mocha or directly with foam or with glue, you have the same grade of recommendation that treat collaterals during the same procedure. So, and if we take a look at the American Venous Forum guidelines, we have a strong rate of recommendation for symptomatic patient to treat also the collaterals. So this is why. And then I also give often this answer. I do work in a public hospital in Venice, in which we have done between 2018 and 2024 more than 3,000 surgical procedures for varicose veins, most of them endovascular procedure now. But still, we have in this moment more than 1,000 patients that are awaiting for the procedure. So this means that these patients have basically 1 year to wait for the procedure. So consider that also we have a lot of these patients that are heavy worker. They most of them work in the shipyards. That in Venice it's really important industry. And so most of them are symptomatic. So consider to tell this patient that I'm going to treat the main trunk and then you will come for another evaluation. Then you will wait another year to treat the collateral. So this is really hard to accept for a patient. So this brings us the necessity to do something also for the collaterals. And so these are 3 patients that I had in my hospital, and they have a similar condition in terms of work, heavy work. And in the first one, there was recurrency with huge collaterals. The one that I want to talk about now, it's a chef that has a small restaurant, so he has to cook, but also he's the owner. And so he asked me, please help me because I have two problems. First one, I have to cook, so I'm close to the fire. I cannot wear stockings for a long period. So foam was not for me something that I would propose to this guy. And the second thing is I have to go to work this afternoon. I cannot be at home for recover from huge phlebectomies, for example. So in this type of patient, I think that totally VLA would be a choice. This is the case. So as you can see, there was a incompetent terminal valve at the junction with reflux in both anterior accessory saphenous vein and great saphenous vein with huge calibers, as you can see from this video. There is this is the duplex ultrasound that show us complete reflux from the junction, as you can see. And sorry for the video, it's a little bit slow, but as you can see here, there is a huge reflux, and then both anterior and great saphenous vein incompetency with a huge caliber of both. And we do know that the caliber and the diameter, it's a topic, it's an issue when we consider to treat this patient about the occlusion rate at the follow-up. What the data in this moment suggests us is thermoablative technique are in this type of caliber gives us better results in terms of occlusion rates at the follow-up. So I propose this patient for a totally VLA procedure. As I told you, the reason why diameter, type of reflux, the work, and the necessity to go back to work the same day. And so this is the reason, and this is the follow-up. We decided I treated this patient with laser crustectomy and occlusion with laser thermoablation of both GSV and anterior accessory saphenous vein. But also, as you can see in the slide, the collaterals were treated with the thermoablation, and this is the result only after 7 days. Of course, some bruising. and ecchymosis, but this patient had the chance to go back work the same day with no discomfort, and I'm pretty sure that at 3 months follow-up, the clinical condition and also the aesthetics will be quite better. But about the total EVLA, we have a problem in this moment. We have a lack of data, or no prospective trial about this topic. So we are surgeon and we need evidence-based medicine to confirm what we do and also to adopt a technique and also for the safety of the patient. So this is the reason why we moved and we decided to create this trial. I call this trial Totem trial, means total AVLA multi-center trial, because in this trial, I'm working with other two great center, high volume center. One is in Poland, led by Jan Szczepanski, the Medius Clinic in Torun. And the other one is led by Linas Velika, in Kaunas, Lithuania. So the design of the study is a multi-center perspective, non-randomized, non-blind clinical trial. Every center at the phase 1 have to enroll 50 consecutive patients treated with total EVLA. And we decided to have the same device for the ablation in order to reduce as more as possible some bias. So we're using now third generation laser, 1940 nanometers with 400 microns fiber. The inclusion criteria are basically C2, C6 patients, and the exclusion criteria are the one that you would not treat with laser, of course. So the endpoints, we have efficacy endpoints and safety endpoints that we are now evaluating. For the efficacy endpoints, we are looking for, of course, occlusion rate, 7 days, 1, 6, and 12 months. And of course, we also want to evaluate the energy that parameters such as power button and lead, because I think it's really important now to have a direction also about this to understand which setting is better for this treatment. For the safety endpoints, of course, the complications, but also we want to evaluate the perception of pain during the procedure. This is another, I think, important topic that sometimes other colleagues are asking me, is it painful because you have to place more needles? And so we are now evaluating also this. And of course, the improvements on the quality of life of our patients. I can show you these are the early results that I have in my center. So take this data as initial data, of course, and only of one of the 3 centers. Of course, we have in this moment only the short follow-up. So the 1 month follow-up, 100% of occlusion rate. And regarding the power butts, we have basically 42 joule per centimeter as lead for the truncal ablation. And I remember everyone, I'm using the 1940 nanometers laser. So according to the literature, it's a value that we are used to see. Regarding the tributary ablation, the mean lead was 22. So not too much, but with a good occlusion rate at this moment. But we will see at the follow-up. Regarding the safety endpoint, and I think this is really a nice data to share. Also, if it's of course initial data, is the pain perception was really low. And I can tell you that it's quite similar to the one that we have with the other technique. In our center, we perform all the technique, of course, thermoablative technique, but also MOCA ablation, rotational, non-rotational, foam, and glue. And I can tell you that the pain perception is promising. in this trial. And regarding the complication rate, we had